So sepsis care. Why focus on sepsis? What should we do with patients with sepsis? And then highlight of the CMS core sepsis measure that some of us are hearing about. So why focus on sepsis in brief? Because the incidence is increasing exponentially, because these patients have a longer length of stay and a higher mortality, so they're a huge economic burden on the healthcare system. CMS mandated reporting on specific sepsis measures starting in fall of 2015, and 25% of our hospital-acquired condition score is based upon a score of 8 measures, including sepsis. Also, because there's a huge gap between what we should be doing and what patients are receiving. This is a slide from the Surviving Sepsis campaign, which is a major national and international collaborative sponsored by the Society of Critical Care Medicine that was highly cited as being an effective strategy for improving sepsis care. And indeed it was. But I just want to point out that even after these focused, intensive, resource-intensive efforts, still only 20% of patients are receiving all the measures they should, for example, for resuscitation, and 25% for all management measures. So there's still a gap between what we should be doing and what we are doing. And I think part of the issue is that sepsis, there's not one thing that helps us say, oh, that patient has sepsis. It's not like we get an EKG and they have ST elevation. We said, oh, that patient's having an MI, send off a troponin. It's not that straightforward, right? Sepsis is a continuum, right? So we all grow up with this continuum. There's SIRS, which is a compilation of temperature, heart rate, respiratory rate, white count. If patients have SIRS plus a documented or suspected infection, then we would call that sepsis. If the patient has sepsis and organ dysfunction, we would call that severe sepsis. If that patient has severe sepsis and they require vasopressors to maintain a blood pressure, we would call that septic shock. That definition was around for close to 2 decades and now was recently revised. So it was revised in this way. Sepsis is now what severe sepsis was, right? So there's no SIRS. So the reason why this, a couple of things. One, there was concern about the applicability of this definition for benchmarking to advance the research world. There was also concern that SIRS, as the criteria was defined, impacted over 50% of all hospitalized patients. So as CMS was gearing up for financial incentives, they thought it would be overburdensome for us to be screening over 50% of all hospitalized patients. So there were a number of reasons why this definition changed. So sepsis is now what severe sepsis was. There's no SIRS, right? And septic shock is that subset of sepsis with circulatory or metabolic dysfunction associated with higher risk mortality. So again, sepsis in the place of severe sepsis. This definition comes along with some clinical criteria too. So sepsis, more specifically, is the suspected or documented infection and organ dysfunction as measured by this scale called SOFA, or Sequential Organ Failure Assessment Score. I have a slide of that. And then septic shock would be sepsis and vasopressor therapy needed to elevate MAP and a lactemia after adequate resuscitation. So here's a measure of the SOFA. It compiles a number of different systems. It's kind of like what severe sepsis was, right? When we thought about we had organ dysfunction, now this incorporates that into the fundamental diagnosis of sepsis, and that's here available if you need that. This also came along with a tool called a Q-SOFA. So SIRS is no longer considered in defining sepsis. Quick SOFA, or Q-SOFA, is the bedside prompt that may help us as providers heighten awareness about these patients who have a higher risk for mortality. There are 3 criteria for Q-SOFA, so low blood pressure, higher respiratory rate, and altered mental status. So the idea is that if I'm out on the ward, if I'm rounding, and I see a patient who's tachypnic and has altered mental status, oh, that could be sepsis. What about the patient I see who's tachypnic and a little hypotensive? oh, that could be sepsis, right? So it's trying to prompt us to see these patients in a different way. So when we trigger, same way we say, oh, that's an MI, I need to do boom, boom, boom. Now it's when I see patients with sepsis, I need to do boom, 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 boom. What should be done for patients with sepsis? Well, the best by far resource that we have is the Surviving Sepsis campaign. Includes 93 recommendations, just updated in 2017. So that's clinically what we should be doing. A little bit of the conflict comes in with how CMS is measuring our organizations and what we should be doing. May not be exactly the same thing that clinically that we do. So I don't know if you guys are hearing about this, but we certainly are from our administration to make sure that we're documenting care provisions that not only meet surviving sepsis, but also meet the CMS criteria for what they think we should be doing. And that's a very complex measurement system. It's all or none, so if you miss any, you get no credit whatsoever. And it's unclear if those CMS definitions are going to be modified based upon the updated surviving sepsis or clinical definitions of sepsis. Make sense? So we're a little bit at a disconnect right now.